everyone, I'm Kirsten Davidson, your host and creator of my wellness podcast, Mind the Gaps, where we work on surrendering our typical ways of looking at life to step out of our comfort zone and into our growth zone. Welcome to the re-release of my podcast episode most near and dear to my heart from 2024, DiagNOsis, now released as episode number 28, DiagNOsis Reawakened. So why did I decide to re-release this episode? Firstly, after I'd finished my undergraduate degree, I learned about the limitations of so-called mental disorders or mental illnesses, and this is what sparked my passion to advocate for a more holistic approach to mental health. Second, now that I have a psychotherapy practice, I want to emphasize now more than ever how we all have the power to transcend suffering. We're not doomed to be victims of our experiences nor our genetics. And thirdly, I recently attended a talk in Toronto by Gabor Mate, the physician and psychotherapist who authored a book called The Myth of Normal, which was one of the fundamental books that inspired this very episode. At the event, Gabor let us in on what he called a little secret unbeknownst to most psychiatrists who hand out mental illness diagnoses. And this secret is that every so-called mental disorder can be traced back to trauma. And so there's nothing fundamentally wrong with anyone. Instead, every single unhelpful thought, emotion, or behavior that we experience to date has its roots in early adaptations. What Gabor means by this is that every trauma response, every so-called illness, disorder, or symptom that shows up today once served us as a mechanism for survival. I'll say that last bit again. Every so-called illness, disorder, or symptom that shows up today once served us as a mechanism for survival. Before I attended this event, I listened to episode number 9 of Mind the Gaps, DiagNOsis, released in June 2024. And as I listened, I felt that same excitement, passion, and eagerness to share these messages all over again, and all with the intention of empowering us to liberate ourselves from suffering by facing our pain rather than identifying with it. Facing our pain, moving through it, and coming out a more evolved version of ourselves rather than staying victim of circumstances. And all of this brings us to today, an invitation to join me on this exciting path of discovery, liberation, and transcendence. For all things Mind the Gaps, you can find me on Instagram at kirsten.davidson in addition to my new website, mindthegaps.co. If you like what you hear today, taking a moment to rate and review the podcast episode is always greatly appreciated. We couldn't do this without your support, so thank you so much for tuning in, and I hope you enjoy. Okay, so this is a big topic. Diagnostics for mental disorders and all the narratives around them. This is actually the topic that first lit a fire in me to start looking differently at traditional models of mental health. And because of that, this episode is very near and dear to my heart. As I mentioned in episode 1 of Mind the Gaps, 21-year-old me read a book called Lost Connections, Uncovering the Real Causes of Depression, written by Johann Hari, and my mind was blown. Everything that I thought I knew about the typical medical model of mental health diagnostics and treatment was put into question. My faith in these practices started to falter, and here's why. The medical model of mental health supports diagnosing individuals with labels known as mental illnesses. Throughout this episode, whenever I say diagnostics, I'm referring to labels of so-called mental illnesses and mental disorders like depression, anxiety, OCD, PTSD, and so forth. Many researchers, professionals, and myself in the field of mental health have concerns with the diagnostics model for two main reasons. One, diagnostics of disorders are pathologizing. Pathologizing means to say that there is something wrong with us, that our human experiences of sadness, nervousness, trauma, etc. make us faulty and abnormal. Two, in an attempt to categorize and make sense of who we are, diagnostics way oversimplify the human experience. We don't and we cannot fit into boxes. I'd like to share a visualization exercise that I use to help explain the difference between medical versus more holistic models of mental health. Take a moment to imagine a beautiful potted flower or plant, one that you'd like on your windowsill at home. Now imagine you wave a magic wand and produce an identical clone of this plant. Same genetic makeup, exact same plant. Let's put one plant on your windowsill where there's lots of sunlight and you'll remember to water it, and let's put the other plant in your basement where there's no sunlight and it'll likely be forgotten about. Imagine a week has gone by and you retrieve both plants to put them on your living room table side by side. To you, it's completely unsurprising that the basement plant is dying at best, if not already dead. Its leaves are wilted, brown, and shriveled. It's also unsurprising that the windowsill plant is tall, green, and blossoming. Each plant has completely different lived experiences, and so one thrives and one dies. But what if a friend came into your home, looked at these plants, and said the dead plant has something inherently wrong with it, that it's got a disorder, that it's abnormal? What if the friend said that the plant is being dramatic and that it's shriveling when it shouldn't be shriveling? This friend might also suggest putting miracle growth on the plant to fix its problems, all while failing to ask about the plant's environmental factors. To you, it makes sense why it's dying. To this friend, there's something inherently wrong with the plant itself. The medical model of mental health is the equivalent of looking at people's undesired emotions as individual problems rather than as a natural and normal response to poor or challenging life circumstances. The holistic model of mental health looks at the room that the plant grew up in, understanding how and why it has shriveled, and all while advocating for this plant to graduate from the basement to the sunny windowsill. As said by Hungarian and Canadian author and physician Gabor Mate, we have to start seeing people not as what's wrong with them, but as what has happened to them. I'll say that again. We have to start seeing people not as what's wrong with them, but as what has happened to them. So where did diagnostics come from? The first edition of the Diagnostics and Statistics Manual for Mental Disorders, DSM for short, was first published in 1952, followed by 4 more editions, which brings us to the DSM-5 published in 2013. There are a series of mental health questionnaires associated with each disorder for determining whether a client, quote-unquote, meets the diagnostic criteria for a specific mental disorder. If the criteria is met, it's said that the client has a disorder. So they have depression, they have anxiety. Over the years, the DSM has been expanded and revised, and it's been criticized for its quote-unquote black and white approach to complex mental health concerns. Even researchers supporting the DSM have acknowledged that diagnostics are not objective. They say that it's the clinician, the therapist, that is ultimately the diagnostics tool. This means that whether or not a client meets or does not meet the criteria, it's up to the therapist to say whether or not they have a disorder. And it's said that it's up to the therapist's clinical judgment to make this call. This is where medical models clash. See, if you have a broken arm, for instance, you get an x-ray. You and the doctor can see that your arm is broken, and so it's deemed that you have a broken arm. You get your cast and some pain meds and eventually recover. It's objectively broken, and we can say that with confidence. Now, I'd go as far as to say it's insulting to try and distill the mysteries of the human mind to categories and labels. It's as though the DSM is a feeble attempt to feel like we're in control and fully grasp these complex mysteries of the mind, but we can't always see what's going on in the mind. Where does trauma live in the brain? Now, you might be thinking, but there are brain scans that show how mental health concerns show up in the mind. For instance, depression is visible through lower levels of brain activity, and anxiety is often visible through hyperactivity in the brain. These brain scans have been used to uphold the narrative that people with depression have quote-unquote chemical imbalances, implying that there is something inherently broken in their brains. What we're missing here is the environment, that the high or low levels of brain activity don't necessarily mean there's something wrong with the person. What it means is that their brain is reacting to stressors in their environment, whether that be internal or external. And so, of course, they feel depressed or anxious. And of course, this shows up in the physical body. At a book talk of his, I heard Gabor Mate explain the problem with diagnostics as follows. So we say they have depression. Why? Because they have the symptoms in the DSM. But why do they have the symptoms? Well, because they have depression. Well, why do they have depression? Because they have the symptoms. This is circular reasoning. As said by Australian-American biochemist Elizabeth Blackburn, so much of what makes people either well or not well is not coming from within themselves, it's coming from their circumstances. It makes me think much more about social justice and the bigger issues that go beyond individuals. For more details on breaking down the myth of the chemical imbalance theory for depression, I highly recommend reading Johann Hari's now infamously quoted on my podcast, Lost Connections. Let's dive into the science of genetics for a moment. When we apply a medical framework to mental health, we mistakenly place a ton of emphasis on so-called mental illnesses being genetic, that is, being passed on to us. This puts us in the role of a passive recipient of our fate rather than an active participant in it. Based on what we now know about genes and epigenetics, we're not doomed to our genes because genes are only expressed through our interaction with the environment. Consider your genes as a switchboard. You arrive into the world with a panel of switches, but only some get turned on and off based on your experiences. So while you might have a genetic predisposition to alcohol addiction, for example, this gene won't necessarily be expressed unless triggered by certain interactions with your environment. And there's more. Epigenetics is the study of how our genetic coding can actually change throughout our lives because of how we interact with the world. That is, our contact with the outside world over our lives can change our genetic makeup. That's how flexible our brains and our bodies are. Let's go back to the switchboard. Epigenetics tells us that these switches can be removed, replaced, and added throughout our lifetime. As said by Gabor, genes can predispose, but they don't predetermine. This might feel scary to some of us because historically, genes have been looked at as a fixed code for our reality. But even these codes can change? Yes. But isn't that magnificent? It doesn't have to be scary, it can be empowering. We are co-creators. We get to bend and change. We're not fixed, we are flexible. And this brings us back to the subject of mindfulness. As a reminder from episode 1 of Mind the Gaps, practicing mindfulness means to non-judgmentally acknowledge when our thoughts or feelings arise, to face them without judgment, and to let them pass through you. Mindfulness is founded on the core principle that we are not our thoughts, our feelings, or our behaviors. Instead, we are a conscious witness to our thoughts, feelings, and actions. We are more than just our inferences through our 5 senses. This means that we're not our jobs, our homes, our handbags, nor are we our constant thoughts about a breakup, what to cook for dinner, how to pay the rent, and we are most definitely not our mistakes. What else are we not? We're not the wave of sadness we felt when we experienced loss, nor the electric happiness we felt when we accomplished something. The teachings of mindfulness show us that we are not defined by these things. We exist beyond them because we can witness them. We exist as conscious beings who are experiencing the world as it unfolds right in front of you right now. So if we're not our thoughts, feelings, or behaviors, how on earth can we possess them? Diagnostics tells people that they have depression, they have anxiety, they have PTSD. How can they have these things? We wouldn't say that we have happiness. We can experience it, we feel it, it's very real. So why should we say that we have depression? We can experience it, and the experience can be very, very intense, but we simply don't possess it. So not only do we get it wrong when we put diagnostics before our life experience, we simply aren't our thoughts or feelings to begin with. Since we don't possess our thoughts or emotions, we just can't be defined by them. And as said by Johann Hari, we aren't our diagnostics. I was listening to a podcast the other day where Jamaican spiritual teacher Muji was interviewed on what happens to us when we attach ourselves to our emotions. He says, identifying with our thoughts and emotions increases the likelihood that they will come back with more potency. I'll say that again. Identifying with our thoughts and emotions increases the likelihood that they will come back with more potency. When I heard this, I felt this jolt rush through me as I made the following connection. The DSM, in and of itself, is promoting our over-identification with our emotions, which in and of itself can perpetuate, prolong, or even worsen our negative experiences. Now, overriding diagnostics does not mean that we're undermining the very real experience of negative emotions and trauma. It means we're freeing ourselves up to say that the emotions just don't define who we are. Keeping all of this in mind, let's revisit the whole chemical imbalance theory of so-called disorders. To say there's a chemical imbalance is redundant. Yes, of course there's a chemical imbalance because the person is feeling sad. Why are they feeling sad? Because they have a chemical imbalance. But why do they have a chemical imbalance? Well, because they're feeling sad. Okay, enough. Let's get out of this loop and maybe figure out why they're feeling sad. This reminds me of the chicken or the egg argument. What came first? From an evolutionary standpoint, the egg came before the chicken. Why? Because a chicken couldn't just pop up out of thin air. Two chicken-like creatures would have had to mate to produce an egg that then spawned an actual chicken. It's equivalent to asking what came first, you or the sperm and egg that you're a product of. When we look at the dead plant as coming before the dark room, or the chicken as coming before the egg, we miss the bigger picture. But when we look at the dead plant as being a result of the dark room, or the egg as being a result of two chicken-like creatures getting it on, we're giving credit to cause and effect, giving credit to how outside circumstances influence how we show up or whether or not we show up in the world at all. So-called mental health disorders don't come first, the person's lived experiences do. Dead plants, chickens, and depression don't just pop up out of nowhere. So we can see how diagnostics fail to get at the root of why we feel the way we feel. We just look at the surface and slap on a label and maybe some pills too. As said by Johann, it's not a diagnosis, it's just a description of certain behaviors that sometimes occur together. That's all it is. And any brain scan or therapy session is only a snapshot, a moment in time that captures how someone is feeling and experiencing their lives. This doesn't represent who they are necessarily. Our experiences are fluid and ever-changing. The physical and emotional symptoms of depression are normal responses to stressors in our environment. It's not that a person is broken, and it's not something to be fixed with a cast. It's something to be examined in context of the person's life. Every time we wholly examine the person's life, whether it be in therapy or through holistic practices like naturopathy, which we examined last episode, there's always a reason for this brain activity or lack thereof. Now, in my plant example, the clone plants do not have anything disordered about their makeup. There aren't underlying genetic issues that led to one dying and one thriving. Sometimes, though, there does appear to be something abnormal with a quote-unquote seed. Something we might say is abnormal on a cellular level medically. For instance, let's take me as a seed. As I've mentioned before, I have type 1 diabetes, which is by definition an autoimmune disorder. This means that the cells in my body that are supposed to produce hormones to keep me alive don't work. Modern science keeps me alive with medication and technology that I use to manage the condition. No amount of talk therapy can replace the life-sustaining effects of my medication. In previous episodes, including Dr. Curtis Baker and Dr. Kevin Preston, we see how underlying health conditions can actually manifest as feeling depressed and feeling anxious. For example, women with hypothyroidism might be more prone to experiencing a low mood than someone who doesn't have this condition. So we can think of our minds as a mirror of our physical bodies, and our physical bodies as a mirror of the mind. And what I find equally interesting is that our mental health concerns can actually manifest as physical ailments in the body. For example, there are studies that show how women who have a poor view of life before a cancer diagnosis, so more pessimistic view, are more likely to receive diagnoses of cervical cancer later in life. And men who tend to suppress their anger have weaker immune responses to protect against prostate cancer. As I highlighted in episode 7 of Mind the Gaps, Authentic and Accepted, Stifling our authenticity can weaken our immune system and even shave years off our lives. All of this might seem pretty out there, but the findings do check out with what we know about how chronic production of stress hormones, even at a low level, can cause all kinds of health issues from heart to kidney to lungs, you name it. For more information on these types of correlations, I highly recommend picking up Gabor's book called The Myth of Normal, where he unpacks how cause and effect is everywhere. It is everything. Every single human experience does not and cannot exist in isolation of our surroundings. So, where we've really run into trouble with the DSM is treating mental disorders the same as objective disorders in the body that are medically traced. The brain scans I mentioned before reflect depression and anxiety as symptoms. They are symptoms of underlying issues. Let's think of the brain as a mirror reflecting symptoms, whether it be unresolved trauma or objectively disordered bodily functioning. Now, there are a lot of people who report feeling validated by receiving a mental health diagnosis. Of course they would. What's happening here is they're feeling validated the same way we'd all feel validated if we were feeling tired and irritable all the time, and then we were told that we have an autoimmune disease, and that can explain why we've been feeling these things. The thing is, undesired emotions aren't the same as having a medical issue. They can definitely be a result of that, but a diagnostic doesn't get us off the hook for feeling down. As we've seen, the reasoning is circular. Unlike an autoimmune disorder, we have control to cure ourselves of our own suffering. The undesired emotions are not something we possess, we are just not slaves to them. For example, let's go back to when you had a broken arm earlier in this episode. Imagine you wake up one morning and there's this seething pain in your right arm. You head to the hospital, get it checked out, and the moment the doctor confirms that it's broken, you feel validated, of course. You say, oh, thank God, I know why I'm in so much pain now, and we know how to fix it. You get all casted up and you go about your day. Now imagine the next morning, you wake up and you feel that same seething pain in your left arm. You head to the hospital, the doctor tells you that that arm is broken. You say, okay, well, at least we know why it's hurting so much. You get casted up and sent home. The next morning, you wake up to a seething pain in your leg. You know the drill, off to the hospital, confirmed your leg is broken, cast it up, head home. Only now you're wondering, why am I crumbling? Why am I literally falling apart? We know why you're in pain, because your bones are broken. But why are they broken? And we might know you're feeling depressed because of your brain scan. But why does your brain scan look like this in the first place? We can see how mental disorder diagnostics are band-aid solutions, but if we can figure out why you're hurting, why your bones are breaking, we just won't need so many casts in the first place. We can take preventative action. There's literally no single undesired thought, feeling, or behavior that cannot be traced back to its roots. This is one of my favorite quotes by Gabor. He says, "What we call a disorder is revealed to be an ingenious means for an assaulted psyche to absent itself from agony." By this, he means that physical or emotional pain, discomfort, or suffering are normal and expected signals that something is off in our environment. Internally, maybe a medical issue, or externally, maybe an abusive relationship. And with this viewpoint, we can start to look at disorder, disarray, dysregulation, all the disses, as teachers, encouraging ourselves to ask, what can we learn from the pain? Where is the pain pointing us to? For one thing, it can be pointing us to unresolved trauma. Consider the experience of grief. That can be to feel depressed and shocked after the death of a loved one. Of course you're going to feel depressed and shocked. Your points of real-time connection to this person have suddenly vanished. Whether it was expected or not, grief is the catalyst for what most experience as trauma. In 2022, a new label was added to the Diagnostics and Statistics Manual: Prolonged Grief Disorder, PGD for short. Let me read you the overview of the diagnostics criteria. Separation distress, intense emotional pain, and functional impairment, meaning the distress of the death causes impairment in social, occupational, or other important areas of functioning. And all of these criteria must be present nearly every day for at least 1 month after the death having occurred 1 year prior. So if at that 13-month mark after the person passed away, you're still crying yourself to sleep, welcome to having PGD apparently. And one final criteria, cultural and time criteria. Verbatim, the DSM says, quote, "The duration and severity of the bereavement reaction clearly exceeds expected social, cultural, or religious norms for the individual's culture and context. Grief responses lasting for less than 6 months and for longer periods in some cultural contexts should not be regarded as meeting the requirement for PGD." Time and culture. Wow, so if someone you know is experiencing intense grief for longer than 6 months, they've now got a disorder. But if their culture normalizes grieving for longer than that, they don't? Not only are they grieving, now there's something wrong with them if they're grieving too long compared to their peers. Let's hold space for these people in grief, for God's sake. Normalize their responses and help them move through this, not by giving them a label, but by exploring why their grief is so agonizing, normalizing why it is, exploring how they can make meaning of their loss and reintegrate into their lives again. Who gets to decide these things? It's all subjective. Author Michael Singer has said, "Your psyche is a net result of all your blockages and how your energy manages to flow through them." We have the power to move the blockages, so what good does it do to hold on to them and call them us? There are people in my personal life who honor their grief by proudly stating that they will miss their lost partner, sibling, or parent for the rest of their lives, but they've worked through their debilitating agony and assigned positive meaning to their pain. They live as if their loved one is still right there with them symbolically. They speak to their loved one through words, symbols, or signs out in the world, but they dare not say all of this too loud, or they might be called crazy, disordered. We can see how the DSM is trying to make concrete sense of life experiences that could otherwise be met with compassion for the confusion of it all. Loss is absolutely disorienting, but it does not have to be disordered. Another big one that emotional pain points us towards is how isolated we might be. This is the core of Johann Hari's book, Lost Connections. He tears down the idea that we're inherently broken as he traveled all over the world speaking with researchers and residents about why they feel depressed. The biggest missing piece? Social connection. I've referenced just how important meaningful and emotionally safe connection is for our well-being and for our survival. It's no wonder without it, we start to fall apart inside and outside too sometimes. This is why in a first-time therapy session, it's so important for me to ask my clients, do you have any social supports? Can you count on these people? Let's say someone is being emotionally or physically abused, bullied, discriminated, underappreciated, neglected, told that they need to work to earn love by their parents, friends, peers, or by society at large. This person is that plant in a dark room. No wonder they're shriveling. By reintroducing meaningful connection with others, we have the power to rid our minds of undesired emotions and even rid our bodies of undesired diseases. And the same goes for processing trauma. There's a fascinating study which found that meaningful social supports amongst groups of men was shown to reduce their risk of prostate cancer. Just as we can be active participants in the making and unmaking of our own happiness, we can also be active participants in the making and unmaking of our own suffering. And as I say this, I'd like to acknowledge how the larger systemic and societal discrimination at play is something we need to overcome as a collective. However, I'd like to think that by making episodes like this one and urging empowerment and equality in my sessions can help plant some of those seeds in the sun, not in the basement. Let's go back to 21-year-old Kirsten. At the exact same time that my beliefs in the medical model of mental health were faltering, I was also en route to becoming what's called a clinical psychologist. This is a therapist who follows the medical model of mental health and is licensed and expected to diagnose patients. Now, I want to emphasize the term patients here because that is what is used in the medical model. Patients, though, describes a person receiving or registered to receive medical treatment. as I've made quite clear throughout this episode, therapy is not a medical treatment, and so I don't treat it as one. I call my people clients, not patients. But when I was 21, I wasn't aware of this route. In Mind the Gap's terms, the gap between a mental illness and the human beings these labels are attached to was revealed to me. And yet, I had no idea what to do with this information. I thought, how am I supposed to become a therapist when I don't agree with the basic principles? What direction do I take this? Well, at that stage, I had already applied to 5 research-based master's programs in clinical psychology, so I thought, let's see where this goes. This was one of the most academically stressful years of my life. Each program accepted only 1 to 2 research students out of hundreds of applicants, but I was determined to be one. I studied in the basement of my parents' place every day for a standardized test that I needed to apply to the programs. And once all the I's were dotted and the T's were crossed on my applications, I waited patiently to hear back. While I was the top of my class, I was rejected from all 5 research programs. Defeated and with no growth train in sight, I stood in my comfort zone, staring at this massive gap thinking, okay, now what? All I want to do is help people. I need these degrees to do that, and I can't see myself in any other job. When I started to feel a bit less sad and a bit more angry, I contacted some of the university professors in the psych departments that I'd applied to, and I asked what I could have done differently to make my application stronger. The answer was consistent. There's nothing you could have done. It's a numbers game. I started to think, is my livelihood and passion going to be dependent on a numbers game? Do I even bother applying again? One professor was kind enough to call me, and this conversation changed everything. He asked me, how important is research to you? I said, well, I know it's what I need to do to complete a master's and a PhD in clinical psych, so it's important to me because it's part of the process to get me into my own therapy office working with clients. I could almost hear the professor smiling through the phone as he said, and that's why the professors didn't pick you. They want protégés who will stay on working on their research teams after their PhD, dedicating their life to research projects. Based on your application essay, he sighed, it couldn't be more obvious that you want to get through the research to live your passion, day in and day out as a therapist, working with clients. This was a big paradigm shift for me. My first thought was, okay, no problem, I'll just apply next year and emphasize my love for research. But the professor opened my eyes to growth zones that I didn't even know existed. He spoke hurriedly and emphatically, as if he was showing me a secret roadmap and passing a torch that might burn out if left in the wrong hands. He explained that clinical psychology is, quote, on its way out of being the typical treatment for mental health because of its binary medical narratives, whereas something called psychotherapy is moving in. Psychotherapy is the practice of using psychological methods to help move through and maintain mental health from a holistic framework, without diagnostics. What a gift! I could become a therapist and I wouldn't have to pretend to agree with the medical model. I could apply to post-grad programs revolving around the necessary skills for therapy, not around conducting my own research. The knots in my stomach turned to butterflies. I jumped out of my comfort zone and onto my growth train through a practical-based master's program. And after years of hard but exciting work, I arrived in my very own psychotherapy office, working holistically with clients, treating them as the experts of their own lives, helping them help themselves. Talk about rejection being redirection. Talk about gratitude for pain. Because of those rejections, I get to be right here. Not only living and practicing therapy authentically, but also challenging traditional models of mental health on my own podcast. My 21-year-old self couldn't have even dreamed this life. As we wrap up, I invite you to take a moment to imagine waves flowing into a shoreline. Imagine each wave as a thought or feeling you experience. Some waves will come crashing in, and others will be smooth and slow, up and down. Just as with your thoughts and feelings, some will hit pretty hard, in good and bad ways, and some will feel less impactful, more neutral, contented. The tide will change depending on the time of day, the weather, the pull of gravity around it. Consider all the different outside circumstances at play on your thoughts and emotions too. An ocean feels impossible to make sense of, doesn't it? It has depths we can't imagine, and forces influencing it that we just can't control. And yet, there it is, flowing in and out, in and out. You are that ocean. You are that ocean. As said by Michael Singer, if you assert your will against the energy of an event that has already happened, it's like trying to stop the ripples caused by a leaf dropped into a still ocean. Anything you do causes more disturbance, not less. We're gonna feel depressed, anxious, happy, surprised, infatuated, horny, guilty, disgusted, scared, so on and so on. And all of these feelings we will feel as waves. And they'll look different every time. We're not our waves, and we're not our thoughts or emotions. We are the entire ocean. The entire ocean. Let's honor our complexity and start to become more comfortable with the ambiguity of it all. The ambiguity of this experience we call being human. Let's say yes to understanding and validating why we're hurting and why we're happy, all without mistaking ourselves for our waves. Thank you so much for listening. If you're enjoying the podcast, I invite you to participate in a growth zone challenge. I invite you to take a moment, a second, a gap in your day right now and share this episode with 2 other people. Thank you for minding the gaps with me. I'll see you next time on the journey out of our comfort zones and into our growth zones.